A very good morning and warm welcome to this session. We were still hoping for a few extra people who did register to come, but they may be on the way having breakfast or whatever. I would like to start and first of all have a run through a couple of housekeeping announcements. I think, as you know, all meetings are being live streamed on the virtual platform and will be recorded for later viewing. The recordings will be available on demand about a week after the meeting. The live streams will be paused when we break for breakout discussion. I think we will only, with a small number like this, we will not break into groups, but just have a sort of a plenary group discussion that will be only after our coffee break. There are no interpretation features for the breakout sessions. I'm not actually sure if there are for this. I think that applies actually to the whole session, not just to the breakout discussions. The nearest exit to us is over there, right? Okay. And remain calm if an evacuation is needed. So with that, I would like to show you a few introductory slides. First of all, the order of our presentations and our program. The first up to speak will be Dr. Lisbeth Miras, followed by Professor Epco Hasker. And then the third presentation before the break, Dr. Suchitra Lisam. They will each be speaking about current trials, or in the case of EPCO, and the trial that has recently been completed. Then we have our coffee break, and then after the coffee break, Christine will speak about the Bee People trial, which is currently in progress. Welcome to the session. Then Professor Stephen Chambers will talk about the COMBINE trial, which is going on in Kiribati, way over in the Western Pacific. And then we have a concluding video presentation by Dr. David Block. Subsequently, we'll talk in the group, and we will hopefully after each presentation have just a few minutes for some clarification questions, but we'll can leave any topics for the discussion, especially regarding newly emerging research questions or topics for further research to the group discussion. I would like to already thank Joanna Pritchard, who will be is facilitating this session, and Hope Simpson, who is our rapporteur for this session. I would like to, what I'm going to show you is not about chemoprophylaxis, but it's about the context and the reason why we need chemoprophylaxis. Very recently, in July, the WHO published this new technical guidance on interruption of transmission and elimination of leprosy disease. And one of the main new tools in that guidance is this leprosy elimination framework, which sets out the trajectory, you could say, of elimination of leprosy and the subsequent phases that areas or countries go through to reach that final stage of reaching a non-endemic status. What this guidance has also clarified is that unlike most other infectious diseases, the point of interruption of transmission is not the same as elimination of leprosy disease. And so if you look at these phases, there is a milestone that is defined here, which defines the transition from one phase into the next. So the end of phase 1 is if no new orthogonous cases among children have occurred for 5 consecutive years. And so that is a new definition that we use, an operational definition for interruption of transmission. When an area or country has reached that, they move into phase 2 until there have been no cases, even in adults, for 3 consecutive years. And at that point, the country is, if it's at the country level, the country is ready to apply for verification of elimination of leprosy disease with WHO. Then there is a post-elimination surveillance phase, and then eventually the non-endemic status is reached. Now we have a tool that goes along with that. That is an Excel-based tool, which again gives you the same legend here at the top of the phases are colored according to that same traffic light coloring scheme. But the main feature of this leprosy elimination monitoring tool is that it works bottom up. So it visualizes what is happening at subnational level of your own desire, basically. This is at province level in Vietnam, but it can also be done at district level. And it shows very clearly how each area moves through the phases, and in fact, because this is looking back in time, how most provinces have already reached those milestones. And so very often, and that is already the case, certainly in big countries, in districts or provinces in that country, while they are not at all aware of that. And so this visualizes very nicely what is happening and can then be linked with mapping, serial mapping, which shows that the same thing basically, but not in a numerical way, but a very graphical way where you can see what has happened, and in this case the great progress of the Vietnamese National Leprosy Program towards elimination. What we've also seen through this analysis is that secondary cases are extremely rare once you get down to this level of phase 2, and that we are yet to see, after analyzing hundreds and hundreds of these subnational level areas, we've yet to see re-emergence of leprosy. So it seems when countries are really reaching that low level that leprosy gradually disappears. The large-scale rollout of PEP, and that's where our link is with the session, is expected to greatly accelerate the achievement, the time when these milestones are achieved. So with that, I would like to move on and introduce our first speaker. And I'll tell you who she is. Dr. Lisbeth Miras is a medical doctor with more than 20 years of international experience in public health and infectious diseases. She spent years working in Mozambique and Indonesia. At NLR, she is a technical consultant and coordinator of research and advocacy at the International Office in Amsterdam. While working as a medical advisor in countries endemic for neglected tropical diseases, including leprosy, she gained very valuable experience applying science in medical practice. Lisbeth has developed and coordinated several multi-country leprosy research projects. She is currently principal investigator of the EDCTP-funded PEP for LEP implementation trial in Ethiopia, Tanzania, and Mozambique. Lisbeth, over to you.
Good morning, everyone. I have a relatively simple task this morning because I will take you very quickly through some of the scientific evidence for SDR-PEP, and I think all of you in the room already know. So if you catch me making any mistakes, you can correct me, and you can add to whatever I say if you feel the need. And I will also share some lessons learned of implementation projects with SDR-PEP so far. Just to go back to the reasons why it is important to use prophylaxis for leprosy is that, as we all know, the control strategy with early case finding and multi-drug therapy was simply not sufficient to control transmission and to break the chain of transmission. Also, when MDT is given, we know that transmission has already taken place. And even though there are vaccines available, there's insufficient evidence as to how to use them and how they would be best used for prevention of leprosy. What we also know is the risk groups for leprosy, so that's great. We know that household contacts are most at risk, and neighbors in social contacts are also at a higher risk of developing leprosy. And so that makes very clear to us what our target group for SDR-PEP implementation should be. This slide is full of data. It is an overview of the randomized controlled trials with SDR-PEP regarding efficiency. There are 4 trials displayed here, and they all show a similar effect in the range of around 60% risk reduction of developing leprosy. And importantly, the Bangladesh COLAPSE study was a double-blind placebo-controlled trial. So that provides the basis for us to work with SDR-PEP. We know that it works, and that has led us to a multi-country study named LPEP, very familiar probably to all of you, that took place in 8 countries, and that demonstrated the feasibility of the implementation and also demonstrated that SDR-PEP is accepted and safe. More than 99% of contacts agreed to contact screening and accepted SDR-PEP. And no serious adverse events were reported in over 150,000 contacts. Now, what that study has also taught us is that SDR-PEP implementation invigorates leprosy control programs. That is because it's not simply handing out of tablets, but it involves a lot of health education, awareness raising, capacity strengthening, etc., which increases the motivation of health workers to do their job. So they have more to offer than just to say, look, here's your treatment, take it for 6 or 12 months and you'll be done. No, we can also protect your family and friends. Other things we have learned from the LPEP program is that it is very important to provide clear information. Obviously, it's not 100% effective, so people should be aware that they can still develop leprosy after taking SDR-PEP. We should also try to work more on approaches that protect the identity of the index patient, because many patients do not like their states to be disclosed, maybe to household contacts, but not so much to neighbors or social contacts. So it's important to think about this and further develop and test such kind of approaches. What we've also seen is that in very high endemic areas, SDR-PEP implementation given to close contacts may not be enough. So for those areas, we may have to also develop and test other approaches. What we do not know so well yet is what the cost effectiveness of these different approaches is. So that's another field we need to work on. And we try to incorporate that in ongoing studies to learn from these and determine what cost-effective approaches are in different contexts. I would like to show you a few examples here that can further motivate us to continue on this road of prevention of leprosy activities, because in Sampang district in Java, Indonesia, they started using SDR-PEP in 2012. And so since then, you can see a nice downgoing trend, which was of course a little bit affected by COVID, but apart from COVID, it still shows a nice downgoing trend. Sorry. Okay. Apparently one of the slides was taken out, which is fine. This is just to remind you that what I just said is that it's not a simple handing out of tablets. It is really a package of activities that collaboratively lead to strengthened leprosy control programs, reduced transmission, and a reduction of number of new cases. It involves capacity strengthening, it involves awareness raising, it involves stigma reduction, contact tracing, and you name it. It's all necessary to make sure the quality of your intervention is is appropriate. Yeah, so I thought that this slide was coming first, but this is also an example where you can see the downgoing trend after start of SDR-PEP implementation. This is an example in Morocco, which is anyway very low endemic, but SDR-PEP did make a difference, which started also in 2012 and shows a further decreasing trend. Now, one example that I would like to share with you was already mentioned by Wim. The PEP for LEP trial is a cluster randomized implementation trial in 3 countries, Ethiopia, Mozambique and Tanzania. And it compares 2 approaches of SDR-PEP implementation. One is the health center approach, where contacts are invited to come to the health center to be screened and given SDR-PEP. And the other example is the community skin health intervention, which basically looks like this. A health team goes to the community and invites the more or less 100 closest contacts around the index patient for their skin to be screened. And they don't only look at signs of leprosy, but will also look at other skin diseases to be diagnosed and treated. And some of the preliminary results are shown on this slide. It is going quite well, I must say, even though we had delays, of course, because of COVID. What is shown by these skin camps is that they are effective in identifying new patients, because every skin camp leads to, on average, more than 1 new patient. And in the skin camps, more than 50% of the people are diagnosed with a skin disease. That is a lot of people that need treatment or advice how to deal with that. And through the skin camps, by now, more than 12,000 contacts have received SDR-PEP. The lessons learned from those skin camps are that it's important to involve community leaders. That's very obvious. We knew that beforehand, but it is confirmed by observational studies. There's an opportunity for education and on-the-job training during those skin camps. Education on leprosy, but also on other skin diseases. And there is, similar to LPEP, a very low number of refusals, fortunately. And then there's the positive effect on stigma and discrimination, because this is an example of an approach in which the disclosure of the index patient is not required. People are invited without getting information on who is the patient in the context. So that's good. That creates a higher acceptance among patients as well. So there's also a high community turnout. So there are bystanders usually that are very often also screened for skin diseases and even if possible treated or referred. And in Ethiopia, quite a high number of podoconiosis patients was detected, and in Mozambique there were several scabious outbreaks that were represented in the skin camps. Almost done. I got already a signal that I need to speed up. This slide is a graph that is based on mathematical modeling by David Block, who will also be in this session in a video later on. And Anneke et al., they worked on this, and it shows very simply that the more PEP we distribute, the lower the number of new leprosy cases will be. It makes a lot of sense, but to be precise, if we will be able to treat around 40 million people, the reduction will show a decline of 90%. So that's impressive. We should take that in mind when working on SDR-PEP implementation. There are a few interesting developments which will also be presented by my colleagues here, but this is one of them. Rifampicin has recently been tested by Wang and his group in China among household contacts, and it showed to be a lot more effective still than rifampicin, which is exciting because, as I started saying, it's only 60% effective, and there are other ways to increase the effectiveness of prevention of leprosy. Telacebec is not on this slide here, but we are very excited to announce that that TB drug is very potent for Mycobacterium leprae as well. We'll be testing that in mice first and then hopefully do a clinical trial with Telacebec, and that can serve for prevention as well as for treatment. Thank you.
Are there any questions to Lisbeth? At this point, I think we take some clarification questions. Further discussion we will do later on. Anyone?
Is there sorry, please go ahead. Just saying that it is dramatically more effective than rifampicin. Is that going to be replicated, that study, or is there thoughts about going that way instead of rifampicin?
Yeah, we will have to do further studies with rifampicin. It hasn't happened yet because these are very recent findings, but we'll definitely look into that and work on that for sure.
We can come back to that in the discussion later on, but we're currently looking at not just testing rifampicin on its own, but in combination perhaps with this new drug, Telacebec.
Yeah. Excellent presentation, Lisbeth. Just wondering if there is duration in the efficacy, like you have shown the decline in the occurrence or prevalence, but how long has it been consistent? So I was just expecting a slide on that, like how long is the efficacy consistent?
Sorry, do you refer to the mathematical modeling slide or no?
The second one, the changes for each study that you have shown.
Yeah. Yeah. Yeah, well, we know from the COLAB study that you see the decline within the 2 years following the intervention. And, well, of course, the day that the dosage is given is when the effect is seen. After that, people can get reinfected if you don't continue to provide rifampicin to new contacts of new leprosy patients. Yeah?
They have implemented it as a rolling intervention. So every time a new case was found, their contacts were provided with rifampicin. While in COLAB it was just a once-off thing, and then they watched what was happening. So I think that is the reason why we see a more consistent effect over time.
Yeah. Yeah, so it's not a one-time thing. You need to continue to do it consistently.
Nice, really nice as always. Thank you. The skin camp. Now, do you have some data as to what proportion of people who are really the closest contacts actually turn up, or do you find that the men who are out working in the fields don't come? What's the actual take?
No, that analysis still has to be done. So we see that. I mean, we invite around 20 houses around the patient, more or less, and we see that most of them do turn up, but we still have to analyze whether there is a balance between female and male participants, for example, and to check if there is a consistent pattern of people being absent from those skin camps. Yeah, no, that's going to be interesting to find out. That's right.
We'll wrap up the discussion here. So let me introduce our next speaker, Professor Epco Hasker. He's a medical doctor and epidemiologist from the Netherlands with 15 years working experience in low and middle income countries. While abroad, he worked mostly on tuberculosis and leprosy control in Africa, Nigeria, and Asia, Afghanistan, and Pakistan, and in the former Soviet Union, Ukraine, and Central Asia. Since 2008, he has been working in Belgium at the Department of Public Health of the Institute of Tropical Medicine in Antwerp. His core responsibilities include technical support to epidemiological studies in Africa and Asia, lecturing epidemiology and statistics to the International Master in Public Health students. In his department, he is a resource person for technical support on epidemiology and statistics. In 2010, he obtained a PhD based on his research on control of infectious diseases in low-resource settings. In June 2020, he was appointed Professor of Common Tropical Infectious Diseases at ITM. His current main areas of interest and research are leprosy, human African trypanosomiasis, and leishmaniasis. Professor Hasker is principal investigator of the EDCTP-funded PEOPLE trial in the Comoros and Madagascar, testing a single double dose of rifampicin as post-exposure prophylaxis against leprosy. He also leads the new B-PEOPLE trial, also in the Comoros, that compares effectiveness of a combination of bedaquiline and rifampicin against single-dose rifampicin as PEP against leprosy. But that trial will be presented by Christine later. So over to you, Epco.
Thank you very much, Wim, for the introduction. So, yeah, I will be presenting the PEOPLE trial on post-exposure prophylaxis for leprosy in Comoros and Madagascar. It started in January 2019 and ended early this year. Well, Lisbeth already showed results of earlier studies. Indonesia was an environment of very high endemicity where PEP to contacts only had a limited impact, but blanket coverage of an entire island population had a big impact. Then the pivotal trial COLAB Mood et al. Showed 57% reduction after single-dose rifampicin to close contacts. And yeah, recently Wang et al. In China, 41%, but not significant with rifampicin, but rifapentin, 84% reduction. So the PEOPLE trial was a cluster randomized trial. We had 4 study arms, and the intended sample size of 4 times 36,000 was based on an assumed annual incidence of 1.4 per 1,000 in the non-intervention arm and 3 years follow-up, with an expected reduction in incidence of 50% in each of the intervention arms. The regimen we used was single-dose rifampicin, but we used a double dose, 20 milligram per kilogram. That's why we called it single double dose rifampicin, or SDR-PEP. Randomization was by village and per island. In Comoros, randomization was based on the reported incidence over the previous 5 years. In Madagascar, we didn't have reliable baseline data, so we used the first screening round in 2019 for the randomization. So this is the site of the study. 2 islands here, Comoros, between the northern tip of Madagascar and Mozambique. Anjouan and Moheli are highly endemic for leprosy. And then also in red here is Miandrifaso district of Madagascar, the 3rd study site. So what we did, we conducted annual rounds of door-to-door screening in each of the study arms, and any leprosy patient detected was treated. In arms 2, 3, and 4, the intervention arm. On top of that, we gave SDR-PEP to all household contacts. In arm 3, this was extended to anyone living within 100 meters of an index case. And if that was more than 50% of the population, the whole village became eligible. And in arm 4, we gave SDR-PEP to anyone living within 100 meter of an index case and testing positive to anti-phenolic glycolipid 1, anti-PGL1. Yeah, we did these 4 rounds of door-to-door screening, and our main outcome measure was the incidence rate ratio between the arm 1 and each of the other arms. And yeah, we used electronic data capture, which allowed us also to record the geographic coordinates, and all incident cases were that all gave their consent were sampled in a sub-study. So the main outcome was the incidence rate ratio between arm 1 and each of the 3 intervention arms, sorry. For that we fitted a multi-level random effects Poisson model with village nested in randomization block nested in island as random effect. But we also looked at the individual effect of PEP, controlling for confounding by gender, age, and in particular distance to nearest index case. And from these samples of leprosy patients, we did qPCR, and if there was sufficient DNA, we also did phylogenetic analysis. So we enrolled a population of 110,000 roughly, less than expected because the population figures in Comoros were not accurate, unfortunately. Yeah, average follow-up time, 95,000 of those had at least one follow-up, so could be evaluated, and average follow-up time was 926 days. Shorter in Madagascar because there we could only start the intervention in the second year. So altogether we found 885 leprosy patients, 456 were incident cases, were prevalent cases, sorry, at the time of baseline. Incident cases we had 265, very few on Madagascar, many on Anjouan. And then we had also 164 other cases. These are patients that were detected after the baseline survey, but were not under follow-up yet at time of detection. If we use the incident cases, we had an average incidence rate of 10.9 per 10,000 per year, so pretty high. How was PEP issued across the study arms? In total, we issued about 19,000 doses of PEP, at least once to each person. The household contacts in each of the arms were roughly 2 to 3%. In arm 3, about 50% of the population in the end was eligible. In arm 4, it was about 11%. Now, how were the cases distributed among the study arms? Well, you see the prevalent cases there. We had hoped that it would be more or less balanced because we had randomized, but in Comoros, this was based on the reported incidence over the previous 5 years, and that turned out to be not very reliable. There had been quite a few hidden cases, so we ended up with a far higher baseline prevalence in arm 3 and the lowest in arm 1. If you look at the incident cases, we see more or less the same numbers in arm 1 and in arm 3, a bit less in arm 4. Now this is the same in a figure. R1 is the baseline survey, R2, 3, and 4 are the 3 follow-up surveys. In red, the cases after PEP, mainly in the blanket intervention arm, and in blue, the cases without PEP. It seems that arm 4 is doing a little bit better. At first glance here, you don't see much difference between the other arms, and that is confirmed in the Poisson model, where you see that arm 2, well, 20% reduction, arm 4 does a bit better, but nowhere near statistically significant. But then we have seen that the baseline prevalence was much higher in arm 3 and was the lowest in arm 1. And if we control for that by, instead of using village as random effect, using baseline prevalence in the village as a fixed effect, then arm 3 becomes significantly better, and arm 4 becomes borderline significant. Yeah, the effect of closeness to a prevalent case at baseline is what you see here. Among those who lived at baseline in the same household as a prevalent case, you see the risk of developing leprosy over the follow-up period was roughly 10 times higher than for those who lived at 100 meters or more, and there was a nice gradient. So if we put all this in an individual model, Then we see that PEP at individual level protects, 45% reduction and significant, and the effect of distance remains, household contacts 4 times higher risk, neighbors up to 75 meters 2 times higher risk. BCG, not a confounder, but we also kept it in a model because it also protects. And we also tested for an interaction between BCG and PEP, but found no signs of that. The p-value was 0.99. Some additional things we did. We collected samples of all the incident cases, and you see that for those where all those that consented and did not have a single lesion in the face, because then we wouldn't do it, we had 178 samples available. 87% of those were confirmed, so excellent diagnostic skills in the field. And also, if you look, you see that the highest proportion of confirmed PCR is in arm 1. So even though the study was not blinded, I don't see any indication for a potential bias here. Often it is said that PEP would only protect against PB leprosy. We did not find indication for this here in our study, because among the failures on PEP, 31% were MB, whereas overall the proportion of MB was higher than that. We also know that blood-related contacts are assumed to be, that PEP is assumed to be less effective in blood-related contacts. As a proxy, we looked at household contacts. And again, in this study, we didn't really find a confirmation of that. The effect was a bit stronger even in household contacts. And that, in combination with a much higher risk among household contacts, caused that the number needed to exposed in household contacts was only 82. So for every 82 persons given PEP among household contacts, you would have prevented 1 case. Overall, that figure was 870. So conclusions, we see that PEP does appear to protect both at individual and at the village level. The effect is less than what we would have hoped for, what we had expected based on the other studies. But we also see a strong association between risk of incident leprosy and distance to another leprosy patient. So our recommendation would be to do a well-targeted active screening, and then if you do around the index cases, and if you do that active screening, giving PEP in addition is hardly an extra effort. But we need to explore also stronger PEP regimen, perhaps based on combinations of drugs. So finally, I want to acknowledge our partners and our funders, and in particular, the National Leprosy Control Programs of Comoros and Madagascar. Thank you.
So we have a few minutes now, please. I think probably people can hear me without a mic. Any questions for clarification at this point?
You are super clear.
You're very clear. Yes, that's true.
I think we just should say what a great study it is, actually. I mean, it really is a fantastic study, and in my opinion, and well done doing it. And I really like some of your extra points of that you've made at the end there, which I'll read with interest when this is published. Is this published yet?
It's submitted.
Submitted? Oh, I'm not a referee, so I'll...
Okay, well, if there are no further clarifications, then thank you again. Let's go. Yeah, I think one of the most encouraging things was that it was also significantly effective in household contacts. I think that's that, along with the fact that you dispelled some of the myths of the fact that it would not work in household contacts, and that it would not work to prevent MB leprosy. To me, seeing the results being, say, perhaps slightly less effective than in the COLAB study is understandable given the incredible high incidence of leprosy, especially in the Comoros. And so this is a great trial, great result indeed. So we go to our third presentation now of this morning. And that will be given by Dr. Suchitra Lisam. She's a public health specialist with a medical background and a master's degree in public health and a postgraduate degree in epidemiology of HIV/AIDS. She has worked for the government of India under the Ministry of Health and Family Welfare and several international NGOs in managerial and leadership positions in the past 15 years. She had evaluated the National Health Program, drafted policy briefs, and contributed in development of national guidelines for the government. She's currently leading the PEP++ trial in India and heads the Research and Knowledge Management Department at NLR India. She's passionate about working for the most marginalized people, such as persons affected by leprosy, NTDs, and HIV. And she's contributed towards improving their access to health coverage, rights and entitlements, and quality of life. Suchitra, the floor is yours.
Good morning. Am I audible? A very good morning to all. Thank you, Dr. Wim, for the kind introduction. Yes, I'm working with NLR India since 2017, and it's a pleasure to present the PEP++ Enhanced Chemoprophylaxis trial on behalf of the PEP++ core team that comprises of the following officials from different countries. So this PEP++ study is being implemented in 4 high-burdened countries, namely Brazil, Bangladesh, India, Nepal. And the study is being carried out, in collaboration with the academic universities, Ministry of Health and Family Welfare, with the support of the civil-based organization and NGOs at the local level. Dr. Lisbeth had already covered in detail about the importance of SDR-PEP. So leprosy post-exposure prophylaxis using single-dose rifampicin has been introduced as a national policy and integrated in the routine national leprosy control elimination program in many countries, such as India, Nepal, Indonesia, Morocco, etc. And WHO has already recommended, and they have issued 2 technical guidelines about the using single-dose rifampicin as a preventive therapy to reduce the risk of transmission of leprosy. However, there is a limitation of SDR-PEP, as it is effective up to 60%, to prevent the transmission of the leprosy and thereafter reduction in the new leprosy incidence of new leprosy cases in the community on the whole. But when we look at the close contact, who are blood relatives, who are household members of the index case, it's even lesser. The effectiveness is even lesser at 24%. So considering these facts into account, there is a requirement for a more powerful tool, which we calling as PEP++ regimen. This comprises of 2 antibiotics and which will be administered in multiple doses. So the rationale is that, like the blood relatives are already having higher bacterial load, so it required a more potent, more powerful multi-drug regimen, so that it is more effective. So that is the rationale. The PEP++ regimen, it comprises, as I mentioned, 2 antibiotics, rifampicin 600 milligram and clarithromycin 500 milligram, to be administered to the eligible adult close contacts in 3 supervised doses, and there is a gap of 4 weekly interval between the 2 doses, the first, second, and third doses. Among the children less than 15 years, we are administering these 2 medicines by the age. So PEP++, it is a cluster randomized control trial, and here we are targeting 3 types of close contact: the household contacts, the neighbor contacts, and the social contacts, who had been listed by the detected leprosy index cases, and as well as the blanket contacts. So overall, we are targeting 1,200,000 close contacts in the trial, and in each country, the randomization is done at the block level. So each administrative block is divided into 2 arms. One arm is the intervention block or intervention areas, in which we are administering 20 close contact per index cases, the PEP++ regimen, whereas in the control block and the control arm, we are administering single dose rifampicin to an average of 20 close contact per index case. The key objective of the PEP++ project, the primary objective is, of course, to generate evidence about the effectiveness of the PEP++ regimen as compared with the single dose rifampicin. And the secondary study objective include the 3 different components. That is the acceptability, which we will also conduct as a side study, among the 4 target group, that is the community member, the close contact, the index cases, and the general healthcare worker, about their perception and their, about the views regarding the acceptability of this PEP++ regimen. And the other is the cost effectiveness of the PEP++ regimen, which is also very important, which we will conduct it as a side study. And the other one is the effectiveness of the community education and behavioral change, which we call CEBC interventions. As you know, like PEP++, again, this project is not about, handling, giving the medications, to the eligible contact. It's about getting up the overall health system, in each country. So we focus a lot on the awareness raising, the health education, the BCC component, behavioral change, communication, training, capacity building of the staff, etc. So these are some of the important components. This pictorial diagram, it depicts the 3 different phases of the trial. The one in the orange, these are all the completed key actions that we have undertaken: the leprosy perception studies, the community education and behavioral change, the mapping of the index cases and the persons affected, and the activities which are being carried out in progress are the health system strengthening and training, which is done parallelly, the contact tracing and examination, and administering the multi-drug PEP++ regimen to the eligible close contacts. From next year onwards, what is anticipated is to undertake the blanket campaign with single dose rifampicin and PEP. So with regard to the addressing the community perception and behavior, we have followed this protocol rather. The first, we carried out a perception study, then we address all the knowledge gap, belief, fears and practices through development of all these IEC or the CEBC materials. For this, we conducted series of workshops to select those most appropriate relevant messages, and we undertake communication need assessment because we want to know what are the strategies and what are the medium for dissemination of these materials development, and then we pilot test these materials, and then finally we got them printed, the final version of these tools, and carried out the series of intervention. So this is one of the posters that we have developed in India. Again, in Brazil, similar activities have been carried out, and the poster that developed, the messages are very community friendly, acceptable to the community, and community feedbacks were also taken when we developed this material. So this is again the community sensitization, which we carried out among the community health volunteers, the ASHAs, which we call them in India. The trial inclusion. As of now, 45% of the total targets had been covered in terms of medicating those eligible close contacts. So 33,812 is the coverage in India, and followed by Nepal. We had also faced certain key challenges in the field, Like the adverse events have been reported post-medication, especially with the clarithromycin, and there had been refusal to take the second and third doses of the new regimen. Administration of the repeated subsequent doses also becomes a challenge operationally. And because we have collected huge amount of data, sometime the tablet which is provided and which is used by our research assistant, it got hanged because the tablet has a limited capacity, so there is a need to replace those old tablet. And also we are in the process of migrating the already the completed forms, archiving them so that there is capacity in the device. The confirmation of new cases in the field also sometimes becomes a challenge because health workers are not there all the time. Challenges in giving medication to the young children because sometimes the suspension and the serial forms are not readily available in some of the country, so we have to take that into perspective, and then we have to do some advanced planning. These challenges we had faced in the earlier stage. Now this has been kind of resolved, but those were the challenges. In terms of statistics of the adverse event, total 673 adverse events had been reported across all the 4 countries, and we have already medicated around 73,000 close contact with either SDR or PEP++, and 2.1% of them refused to get administered the second and third dose because of this adverse event. And the refusal linked to the adverse event is around 0.8%. And total 151 new cases have been confirmed out of the trial. So again, as I mentioned, refusal due to adverse event, this is one of the challenges, and we have also replaced the standard clarithromycin tablet with the extended release clarithromycin, and with this, a less number of adverse events have been reported. So this is the timeline, we plan to complete the trial intake, the enrollment and the medication of the eligible contact by March 2024, and also provide the second and third doses up to May 2024. And also start a blanket trial from April, from the second quarter of next year, subject that we get the funding in these 3 countries. And in phase 2, we start with the follow-up. Of course, Brazil had already started with the follow-up because they started 1 year before India and Nepal started. And Bangladesh is the last one to start, but they have picked up very fast. And it's very impressive, the trial intake in Bangladesh. So in all these countries, the phase 2 will start from next year onwards. So lastly, I'd like to acknowledge the consistent support of our funders, the National Postcode Lottery and the Leprosy Mission Trust, and also the members of the Scientific Steering Committee, the principal investigator of 4 countries, the partners of the Ministry of Health, and the universities. Thank you.
Thank you very much, Dr. Suchitra. I think we have 1 or 2 minutes for some clarification. Again, Echo.
Thank you for a very nice presentation. I was just wondering, you are treating the close contacts with the PEP++, and then you are going to do a blanket campaign. Is that with just rifampicin, and how are you going to choose the population for the blanket campaign?
That's a good question, thank you. Yes, we are administering the close contact with either SDR in the control block, control area, and the PEP++ regimen in the intervention area. So coming to the blanket contact, how do we identify those? No? So actually, as per the protocol, we are supposed to do it alongside, the PEP++ regimen administration and also the blanket contacts enrollment. But then the study has been delayed, and that is why we started, quickly with the enrollment of the close contact. But the blanket contacts, those index cases which are already registered. So from there, we will do the blanket contact in which 80, on an average 80 of the context, in the community, of the index cases, that they will be our target. So they will be screened and by a health worker and our staff, and then they will be administered SDR to those eligible one. And whoever is suspected will refer them to the facility for confirmation diagnosis.
Was the clarithromycin or rifampicin given with food or on an empty stomach, or it didn't matter?
That is an important point to consider because rifampicin is more effective in anti-stomach, and clarithromycin, there is less number of adverse event reported, after if you give them after food. But keeping them in mind, like we do administer them, at the same time, but these are some of the questions that we ask, whether they have taken food or not. Because our research assistant, they spend a considerable number of hours in the house, in that community, during the enrollment. So there is, if they haven't taken any food, we ask them to take the food and give it after half an hour or so. So, but as such, we do not carry any food items with us, and we do not distribute anything. Because that is not feasible. It has to be sustainable, whatever we do. Because if the government cannot take it up, it's not scalable, then there is no point.
Thank you very much. I think we need to wrap up the questions here. We'll now break for coffee or tea.
And thank you all for being here this morning. So, as I already mentioned, or as was mentioned before, I'm working together with EPCO at the Institute of Tropical Medicine. And so on behalf of the whole team, I'll be presenting the cluster randomized trial on bedaquiline enhanced post-exposure prophylaxis for leprosy, or in short, the B-People trial. So, as EPCO mentioned already earlier this morning, the People trial conducted in the Comoros showed a protective effect of a single dose rifampicin double dose at the individual level of 45% and 44% at the population level, but actually this was a lower effectiveness than what we've seen in previously conducted studies. And so this difference in effectiveness can likely be linked to differences in the intensity of transmission of leprosy as well. And so it's possible that in higher intensity transmission settings such as the Comoros, we can expect worse outcomes of these kind of clinical trials. And so for this reason, we were looking for a stronger combination regimen to be evaluated as a prophylactic regimen. And so we chose the combination of rifampicin plus bedaquiline. Why bedaquiline? Because it is currently already a new regimen in use for multi-drug resistant tuberculosis, and also in mice studies has been shown to have a very strong effect on Mycobacterium leprae. But so, because bedaquiline hasn't been used for this particular indication yet, before we could start with the actual main trial, the phase 3 effectiveness study, we had to first start with a phase 2 safety study. And so this phase 2 study started or was conducted between July 2022 and January 2023 in one of the non-intervention arm villages of the People trial. And so we recruited participants consecutively in 3 separate age groups. So we started with the adults, and only if the evaluation was finalized in adults, then we continued to recruit adolescents and next children above 5 years old. So we in total recruited a bit over 300 participants who were then randomized to either single dose rifampicin, the standard regimen, or the combination of rifampicin plus bedaquiline, and both doses of the 2 study drugs were linked to the weight of the participants. And so before recruitment or before enrollment of the participants, we first conducted a 12-lead ECG to measure the QT interval as well as liver function tests. QT intervals above 450 milliseconds or liver function tests above 3 times the upper limit of normal were excluded from the study. And then the ECG was repeated at day 1. The liver function tests were repeated at day 14, and if elevated, they were repeated again after 30 days after drug ingestion. And then the adverse events were also monitored up till 30 days post-drug ingestion. And so here we see the measurements of the QT interval for the participants, so both the pre and the 1-day post-treatment measurements. The purple is where they overlap. So as you can see for the 3 age groups, so the above are the children, the middle group is the adolescents, the lower ones are the adults. As you can see, the QT intervals largely overlap pre versus post-treatment. In the adults, there were 2, here we are, there were 2 adults with a long QT already pre-recruitment, so they were excluded from the trial. There was 1 adolescent who had a QT interval of 407 milliseconds and which increased to the borderline of 450 milliseconds 1 day post-ingestion, and that was in the bedaquiline group. And if we then compare the difference between the QT difference at baseline versus day 1 of the 2 regimens, we see that overall, comparing the 2 groups, we didn't see a difference in QT prolongation between the 2 regimens if we combine all the participants together. However, if we look just at the adolescents, we do see that the BPEP, so the bedaquiline enhanced regimen, showed an increase of 10 milliseconds more than in the rifampicin alone group. And this was borderline significant, but we think it's quite unlikely that this difference of 10 milliseconds will actually have any clinical repercussions. If we then look at the ALT, so the liver function tests, we again see that they largely overlap in all 3 age groups when we compare pre- and 14-day post-treatment measurements. There were a few individuals in the children and the adult groups who had indeed higher liver function tests at day 14, so more than 3 times the upper limit of normal. But they all remained asymptomatic and they all spontaneously resolved to normal values again when we repeated the liver function tests at day 30. For the adults, so the group that was first recruited, we had unexpectedly high liver function tests, and this was due to a technical error which was then resolved before we continued to recruit the adolescents and the children, fortunately. We conducted external quality control, and there it was confirmed that indeed within the normal range limits there were inaccuracies, but most importantly that in the elevated ranges the results were valid. So that was important. And then if we, instead of looking here by age group, we again compare the difference in the change of liver function tests pre versus post-treatment between the 2 treatment regimens, we see that the differences between the 2 regimens are really minimal, and the differences are not significant either way. Then we had 2 serious adverse events during the study, so 1 in each of the 2 study regimens, but both were deemed not to be linked to the study drug ingestion. And then we had non-significantly more frequent adverse events in the bedaquiline group compared to the rifampicin alone group. And in adults, this was mainly nausea, dizziness, headache, and diarrhea, and in the adolescents, mainly headache. But so based on these results, it was deemed that the bedaquiline enhanced group was equally safe as the rifampicin group. So we got the green light from the Data and Safety Management Board to continue with our phase 3, which is the main cluster randomized trial, also conducted in the Comoros to evaluate the effectiveness of the bedaquiline enhanced regimen compared to the rifampicin alone. So in this study, all the inhabitants living within 10 minutes of an index case, which is diagnosed with leprosy in the last 5 years for the first year, will be randomized to either arm 1, receiving single-dose rifampicin plus bedaquiline to be repeated after 4 weeks only in the household context, or to arm 2, which is just a single-dose rifampicin. Of course, again, there are some weight and age limitations for the eligibility. Maybe also important to mention is that if more than 50% of the villages were eligible or were living within 100 meters of an index case, the whole village was eligible. But again, of course, depending on the individual inclusion-exclusion criteria based on age, weight, and also active disease or previous ingestion of either one of the study drugs in the last 2 years, etc. So we aim to enroll a total of 124,000 participants, of which we expect 70,000 to be eligible for PEP. Presuming an animal incidence of 11 per 10,000, we expect to have a 90% power of detecting a difference of at least 50% between the 2 study regimens. And then on the randomization process, I'll go a bit more in depth in the next slide. So here you see how we did the randomization of the different villages. So the study started in March 2023, and randomization was mainly based on leprosy prevalence in 2022, and this was based on door-to-door surveys. So for the villages that were part of the PEOPLE trial, we used the final screening round of the PEOPLE study. For new villages, we conducted a door-to-door screening in the second half of 2022. And then the villages were grouped per island, so Anjouan versus Mohéli, and then per arm within the PEOPLE trial. And then they were listed in the order of descending incidence, and then within each pair, they were attributed to either arm 1 or arm 2 of the study drugs. All of the villages will undergo 3 annual door-to-door screening rounds, and the first 2 of these screening rounds, we will deliver the PEP to the participants. So primary objectives is to evaluate the effectiveness at the individual level, comparing both regimens, but we will also look at the effectiveness at the population or at the village level. We will monitor adverse events. We will also assess cost effectiveness of both regimens. Also, traces of resistance will be monitored in both leprosy and TB patients. And at the very end of the study, we will also repeat the anti-PGL1 serological surveys so that we can compare the trends in seroprevalence at the start of the PEOPLE trial in 2019 versus after 7 years of intervention, which will be in 2026 then, to see if transmission has come down as well. Just a brief update, because I think my time is almost up. So far we have registered around 95,000 people in all these villages that are to be enrolled. This number is still likely to increase because not everybody was present at the baseline surveys, and they haven't all, so absent people haven't yet given their informed consent to be enrolled. About 16 to 17,000 have been examined so far, and PEP has been distributed to a bit over 10,000 people at present, with only minor side effects reported and a really high acceptance rate. So that's nice. Timelines then, so we've started in March of this year. The screening is taking a bit more time than we initially anticipated, and I think this is also partly because in most of these villages, more than 50% of the village is actually eligible, so we're treating whole villages in a majority of cases, so it's taking a bit more time than initially anticipated. So we hope to finalize by the latest by August 2024. A second screening round will then be done by 2025, and we hope to finalize the final screening round by February 2027, so that we can close the database and hopefully by mid-2027 have the final results. So I would like to thank all the people who are making this possible, specifically the teams in the Comoros who are working really, really hard in not so easy circumstances to reach all these people and reach them again and again. And of course the participants themselves as well. So thank you.
Hang on to the mic for a sec. Is there any clarifying questions at this point?
So bedaquiline is presumably active against MTB as well, is that correct? So are you doing any screening for tuberculosis at the same time, and do you have any worries about any impact that your prophylaxis may have on resistance for TB in the long run?
Yes, I think that's a very fair question. EPCO, please complete if I'm if I'm not giving the full picture. But indeed, there has been a lot of worry of concerns that have been uttered with regard to resistance development. And so for this reason, indeed, we're following up. We did a baseline genotyping already. So at present, there's no traces of resistance. But we will indeed continue to follow up all the leprosy patients and all the TB patients. And really do genotyping to identify the first traces of resistance in all of the cases. But maybe, EPCO, you want to complete any?
And during the screening, we will exclude anyone with potential symptoms of tuberculosis.
Okay, well, thank you very much indeed, Christine. I guess indeed from the study that EPCO presented earlier, there was also molecular genetic work done on detecting early resistance against 3 different drugs, I think. And that showed that there was no sign of any increase in the people who had received the rifampicin. So that was, in a way, also putting some fears to rest, that single-dose rifampicin might contribute to resistance developing, not so much in leprosy, but in TB, although I think you looked at both, in both M. leprae and M. tuberculosis. In the people.
In people, we look at both. In
yeah.
people, we only looked at the leprosy.
Okay.
But we also look at minority populations of resistant mutants and prognotin.
Right. Okay, so then it is my pleasure to announce the next speaker. Professor Stephen Chambers is an infectious disease physician based at the Department of Pathology and Biomedical Science at the University of Otago. Do you pronounce it like that? In Christchurch, New Zealand. He's a board member of the Pacific Leprosy Foundation, which has been influential in implementing leprosy control programs in Pacific Island countries. This includes a post-exposure prophylaxis program in Kiribati, Samoa, the Solomon Islands, and Vanuatu. Prof. Chambers is principal investigator of the COMBINE trial, a trial in Kiribati testing combined post-exposure prophylaxis against tuberculosis using the 3-HP regimen and leprosy using SDR-PEP. He has a strong interest in the epidemiology of antimicrobial resistance, as well as stigma reduction programs in leprosy, as well as tuberculosis and other neglected tropical diseases. So that's a lot. But okay, over to you.
Thank you, Wim. It's very nice. I'm a Johnny-come-lately to the leprosy world, really. My career was in infectious diseases, and then the Pacific Leprosy Foundation is a very small charity based on the city where I live, and they said, would you like to come and contribute? And I said, well, that would be interesting. And it's been an amazing story, and I've got to know a lot of you people, so that's really nice. And in particular, Dr. Tamea is in the background. He's from Kiribati. He was sponsored by the foundation to do his training in dermatology, and so he's now leading the program in Kiribati. So at the end, he can answer any tricky questions about it. This is the COMBINE study, COMBINE because it's a combination of TB and leprosy. So it's a very high incidence country for both TB and leprosy. So in case you don't know, Kiribati is a country here, which was formerly the Gilbert and Ellice Islands, but then they lost the Alice, so that became Tuvalu, which has also got a high rate of leprosy. But here's the rates of leprosy here, and here's tuberculosis. So we're working in an area where there's a lot of it, and we're really quite concerned. When we went to the Ministry of Health initially, they said, you must not cause resistance to rifampicin, either TB or leprosy, if you're going to do this project. So we're rather sensitized to the amount of rifampicin we're proposing to soak in a population where there's obviously issues about other diseases and resistance. So I got a bit involved back here somewhere. The highest number of cases, annual cases, was here. And just a little bit more about the geography. The major population is in South Tarawa, and this here in Beso, which is 1.4 square kilometres, has 20,000 people, and basically we think everyone's a contact. So it's a very high population density. And then in other islands it's somewhat less, but there's still a lot of leprosy in this area here. And this is where the airport is, and the administrative centre, the port, and it's all linked by a causeway. It's the only country both north and south of the equator and east and west of the dateline. So just a little trivia question in case you get that in the local quiz. So there's a story here, but this is really important. So back here in the 1990s, the whole of South Tarawa was examined and given SDR, single dose rifampicin together with minocycline and clarithromycin. And you can see this huge number of cases that occurred. And basically it reached, quote, elimination levels for one day, one data point. And then look what happened. So if you take your foot off the neck of the snake comes back to bite you. And you see this is where various interventions were taking place. So trying to, usually just interest because of somebody in particular. I got involved somewhere around here, and we gradually tried to strengthen the program. And we got to about here and we thought, well, we've got to do something a bit different. And then all the data, of which you all know better than me, from COLAP and so on, came out. So we thought, well, perhaps we should go ahead and put in a post-exposure prophylaxis program, which we did, but not before we'd done some modelling. So this is modelling done by David Block up in Erasmus. This is the SimCoLab model, of which some of you will be much more familiar with me, and I don't pretend to understand how all these bits worked, except our master's student had to get all the data out of the census data and plug it in. But what it showed was important, and that is that if you gave SDR-PEP, then you would expect to see a slow reduction of cases, as has been demonstrated to be true in some of the other studies. And it would be rather a slow onset, and it would take some time to reach full benefit. If, on the other hand, you gave mass chemoprophylaxis, you get a rather rapid decline in cases. And if you did both, you get a line that looks a bit like that green line, and you could we modelled various doses. So we thought, well, the best thing to do both, but we just didn't have the resources. So we put in place the PEP program for household contacts, which is another story I'm not talking about. Then because I've been working there, some folks from the University of Sydney phoned me up and said, we're wanting to put in a TB project. We're done a lot of work in particularly Vietnam, and we want to screen and treat a whole lot of patients with for tuberculosis, and could we work there? And I said, yes, I think that the political situation will be such to be a good idea. And I said, well, by the way, we want to do mass chemoprophylaxis. So we said, well, why don't you screen for TB, and we'll look at everyone and see if they've got skin lesions and whether they have leprosy. So here's the combined project. And so the question was really, is active case finding and treatment combined with population-wide mass drug administration with either single-dose rifampicin or rifamycin-containing TB preventative therapy for reducing leprosy incidence feasible and effective. So this is combining a TB and a leprosy program. And of course we're wanting to minimise, because of the TB issues, we're wanting to deal with that at the same time if we can. And here's the primary outcomes: new case detection rates in South Tarawa, new case detection rates compared with the outer islands where this is not happening. And then we'll do a survey of Beso in particular to check and see whether it's working in the long run. So this is sort of a cartoon of what we're doing. It's house-to-house enumeration and so on. Patients are given information and consented, and then they're invited to come along and to have clinical examination. Everyone gets a chest X-rays read by AI and gets a PCR of the sputum. Anyone who's got TB obviously treated as such. You also get a skin test done, what we call sleeping. Not allowed to call it latent infection these days. We've got to call it something else, so we just called it sleeping TB for communication's sake. And so they got a skin test done, and then everyone's looked at for a skin lesion, and then they're seen by the leprosy team, and biopsies done for confirmation and for also for resistance testing. So a pilot study was completed in 2022. This is the only data I'm going to present. This is a village in South Tarawa, and you can see that in this area there's about 1,000 people, and there was thought to be on the census about 176 households. There's actually no addresses in Kiribati, and so actually it's not quite sure what the geographic thing should be when you've got very dense populations. You can see the average number of people per household, which is slightly lower than I expected. Here's the total population. You can see here in the enumerated plus the census data, so slightly more people there. And here's the number who participated, which is 75%. So that left out 25%. There's more females than males participating in the pilot study, which was a slight worry. I think the males are often not present for other reasons or a bit more gung-ho about their health. And you can see here that we had, of those, 761 had a negative skin test. And those considered for SDR, these are the exclusion criteria essentially, and only 6 people refused. So as in all the other studies, it's a highly acceptable thing to be for people who know there's a high instance of leprosy in their region. Everyone's looked at for a skin test. One of the leprosy nurses is embedded in the program to improve the sensitivity and specificity of the initial screening and testing. And you can see here that we had about 80% had a visible scar for BCG, which is of interest. And you can see we only had, we had 1%, 10 out of 1,000, 1% confirmed leprosy. So the rate is 1% of the population. I mean, it's kind of astounding to me still to think those numbers are real. So this is a survey of our results. So those were enumerated, 1,300, less than 3, there were 79, 1,225 eligible. Then there's those who are registered, and then those who consented, BCG scar. And we found 13 new cases of tuberculosis, 10 new cases of leprosy, another 112 patients, 12% who had TB infection. So we're then administering rifamycin-based therapies to these patients, and those patients. So that makes, 12, 14% or so. And then the others are getting SDR, and again, there's a high rate of agreement to it. So there's a large proportion of the population, depending on which bit of the you choose as your denominator. But it leaves a group that really we need to follow up and give a mop-up to try and give a second chance to. And it's like all these things, what happens in weekends and what happens in after hours, and then we're trying to find extra funding to get the nurses to go and see all those people that haven't been seen on the first occasion. So, do I think it's working? Yes, I think we've got a good start. Scalability is a big issue. The big issue really is number of chest X-rays, because the slowest part of the operation actually is getting the TB side sorted. The leprosy side is actually pretty straightforward. And the team are really experienced, been working in the area for a long time. So these are the leprosy partners. Some of you recognise Arturo Kunin. here's Tamia, who's sitting down the back there. This is Ray, who's the chief of the at the clinic, and Nabura, who's one of our, he's a Kiribati doctor based in New Zealand, who's also part of the team. And then, of course, in the TB side, is Warwick Britton, who some of you may know, and Ben Moran and a few others. So that's what we've got to so far. It's a matter of really of seeing how we can scale it appropriately, but hopefully we'll end up with some mass chemoprophylaxis together with ongoing household contacts are being screened and given prophylaxis as before. So thank you for your attention.
Any clarifying questions to this point?
Thanks for a very interesting presentation and situation there. I was just wondering, 1% of the population having prevalent leprosy and 1% having prevalent TB. How is the healthcare system in Kiribati? How is the access to the healthcare system?
Yes, you might be better asking Tamir about that, but what I would say is that the leprosy side of it is working very well. I think the tuberculosis side is not quite so straightforward. And one of the issues that you face is if you actually start diagnosing a whole lot more TB cases, then what's the slow-on effect in the services about what they can provide? And that's not actually straightforward. So there's some very high-level discussions going on about trying to improve the treatment side of it with the for the TB side. There are services that are there. I personally think that the leprosy side functions at a very high level, but it's patchy, and we have challenges around, particularly around the TB side. And what annoys you so much is there's been all this Gates money going to TB for years. Ah, so annoying. Okay.
I was wondering, do you know anything yet about the sort of baseline resistance, especially the TB side, against rifamicin?
Yes. Do you want to comment on that, Tamir?
Thank you, Professor Steve, for your good presentation. Yes, and according to your question, we have the rifampicin resistant for TB, and it's been they've been detected for more than 3 years, and they've been giving the second drug for the rifampicin. I mean, for the TB resistant rifampicin, and for leprosy, we've managed to coordinate the biopsy for leprosy for rifampicin resistance. From the University of Otago, and so far we haven't detected rifampicin, and we've been only for the dapsons. We've been worried because Kiribati was already been given rifampicin in the previous years that was mentioned, but still this time we've been considering as the rifampicin is as a quite drug for the prophylaxis, or maybe. But we have been doing now just the first study with the foundation.
So you'll be monitoring that during the study?
Yeah, now we've been monitoring patients only for leprosy because we have known that TB already had rifampicin resistance.
Yeah, but the one issue, of course, question that people are asking, is that getting worse because of the fact that you're giving prophylaxis? And in your case, I guess you give prophylaxis on both sides. So you're using GeneXpert, or what are you using for monitoring rifampicin resistance?
Yes. I'm not privy to the TB data, but that they are using GeneXpert, and so there's that data will be available. Certainly, the Pearl team are aware of it, but they haven't just given it to me recently. Yeah.
Thank you. Thank you for your addition here. We have one more presentation that is video recorded. So if we can have that video put ready. Dr. David Block, whose name has been mentioned already, he's a a researcher at the Erasmus Medical Center in Rotterdam, connected to the NTD modeling consortium, and he's done modeling with this so-called SimCoLab model for a long time. And he has been doing a lot of work in recent years on modeling the impact of SDR-PEP and also predicting the impact of PEP++. And I think some of what you showed, Stephen, was also done by David. And so we're looking forward to hearing his presentation now, even though he can't be present among us. Please.
Hello everyone, my name is David Blok and I'm a researcher at the Erasmus Medical Center in Rotterdam, the Netherlands. And today I'm going to present on predicting the impact of PEP interventions on the incidence of leprosy. What can we learn from modeling? So the aim of this presentation is to illustrate or to showcase the potential impact of PEP based on modeling results from different studies. We use mathematical modeling because it's very difficult to establish the impact on the new case detection in trials. The first reason for that is that in leprosy, there's a known backlog of cases. So in the first year, meaning in the first years, you probably will see more cases as compared to a routine scenario. Secondly, leprosy is also known for a long incubation time. So any intervention that is taking place now, its impact or effect might only be visible years from now. And thirdly, the transmission dynamics of M. leprae are nonlinear. Very briefly, what is mathematical modeling? It's basically a quantitative description of epidemiological mechanisms and processes, especially for infectious diseases such as leprosy that behave in a nonlinear way. And it also provides a population perspectives to understand their dynamics. And it's very suitable to assess what-if scenarios, strategies. We can vary assumptions around the effectiveness, but also around the implementation strategies. And that is basically what I would like to focus on during this presentation. So the model that we use in this presentation is the SimCoLab model, which is an individual-based model and a simplification of a real-life situation. The model simulates the life histories of individuals in a population structured by households, the transmission and natural history of infection with M. leprae, and finally also the leprosy control and interventions. And with interventions, during this presentation, we are only talking about PEP interventions. The natural history of infection is modeled as follows in this model. So we differentiate between MB and PB cases. Every individual basically is susceptible, but in a model, but a large part of the population will not develop leprosy. But those who can develop leprosy will enter the asymptomatic stage when they are infected, and afterwards they will, after some years, they will enter the symptomatic stage, upon which they can be diagnosed and treated. Intervention can alter basically this course of infection in two ways. So through the symptomatic stage, through early diagnosis, reducing the time of being symptomatic, and also reducing the time of being infectious in the population, but also preventing them already in the asymptomatic stage. And that is exactly how PEP interventions are modeled. So we assume that PEP is given to a contact of an index patient, and if this contact is in the asymptomatic stage, then PEP might reduce the bacterial load enough, sufficiently, to prevent them developing leprosy at a later stage. All the work before we make any predictions about current control, but also interventions, the work is usually first fitted to observations and validated for observations. I'm not going to show this for every study that I'm going to show in the remainder of the presentation, but this is typically how we approach a modeling study. So in this, this is an example of the LPEP study, of which I'm going to present some of the results later on, which we included 7 high endemic areas in 7 countries, where we fitted the solid line are model predictions to the observations, the dots and the axis. And the shaded areas are the prediction intervals. So in this presentation, we will focus on post-exposure prophylaxis with a single dose of rifampicin. So the way of delivering the intervention is usually as follows, or is modeled as follows. Contacts and neighbors of leprosy patients are systematically traced and screened for signs and symptoms of leprosy. This also might include retrospective contact tracing, so basic tracing and screening of contacts of patients diagnosed prior to the start of the program. So when there are newly detected cases among contacts, these cases will be provided with MDT following standard leprosy control program procedures. But those who don't show any signs and symptoms of leprosy will be provided with SDR. And in the studies that I will show, we assume the following effectiveness: 50% in household contacts and 70% in other contacts. And these numbers were based on the COLAB trial. So in the remainder of this presentation, I will focus on actually three aspects of PEP intervention. So we will compare the differences in impact between having an intervention that is only targeting contacts of an index patient or a complete high risk area. We're also gonna look into the differences between an instant versus a gradual implementation of a PEP intervention. And finally, also we want to showcase or we want to focus on a low endemic setting, the Maldives case study. Maldives is a country that is close to interruption of transmission. And we wanted to show, to illustrate to what extent a PEP intervention could still have a contribution of reducing the number of cases in such a setting. So first of all, I want to focus on SDR or PEP intervention that is delivered through contacts. And I just want to highlight, so these are the results of the LPEP study. And I'm just going to want to focus on three high endemic settings out of the 7, of which I presented the model fitting and validation earlier, and that is Brazil, India, and Indonesia. And the first thing we notice is that the number of contacts that were screened differ tremendously between those areas, with only 11 contacts in Brazil versus 37 contacts in Indonesia. And the second thing we also observe, of course, is that the endemicity level differs between those areas, but also that the impact of the intervention differs between those areas, with Indonesia obviously having a larger impact as compared to the other areas. So what you also see in this picture is that SDR or PEP intervention is always start with an increase in the number of cases, which is the backlog of cases, because of the active case finding component. And because of screening of contacts, you will find more cases among the contacts of an index patient. So after a while finding more cases, we can typically see that depending on the area and of course historic and current control in that area, we can see that the blue line, so the LPEP or the SDR line, so this was the LPEP program, will drop below the routine program. So there's a larger reduction in the number of cases, although there's also a reduction in the time of reaching a certain level of cases. So the marked differences between countries are typically determined by the historic and current control, case finding efforts, and the number of contacts examined. And typically, a PEP intervention that is delivered through contacts can reduce the new case detection rate by 20 to 40%, depending, of course, on the area and country, but also the number of contacts that were examined. So when we focus on high-risk areas, so move away from only a contact-based approach, but targeting a whole area, we can expect that there's of course a larger impact. And this, on the right-hand side, is a picture of the impact of a modeling study based on Kiribati. And here we assume that there's 80% coverage of a high-risk area. So we assume that 80% of the island is covered with SDR, and to showcase its impact. So here the pink line is only targeting household contacts, which already have a huge impact in an island setting with a high transmission, where there's very high transmission. But adding 1 or 2 or 3 times, so to say, an island-wide coverage would further reduce the number of new cases in that island. And the other conclusion that we can draw from this picture is that basically a kind of a mass approach, mass implementation approach, would result in a much greater decline in the short run as compared to a contact-based approach, because it takes more time to reach all the people in the island. So what about the instant versus the gradual implementation? This is still work in progress. So here on the panel, we see the relative change in new case detection rate per million with 2 types of implementation: a gradual implementation, where we assume a coverage that increases from 20% in year 1 to 90% in year 5. And this is a contact-based approach, so targeting only contacts of an index patient, versus an instant approach, where we assume that the coverage is 90% from year 1 onwards. And the thing we can learn from this analysis is that obviously when you take on an instant approach, you will find most of the backlog already in year 1, and then it steeply reduces already, and will go soon under the 1. So basically the 1 is the counterfactual, showcasing that the number of cases will reduce quite rapidly. However, this is obviously an open door, but it's also good to showcase that if you have perhaps a more realistic gradual implementation of such an intervention in the country, that we see a slow increase in the number of cases every year. And afterwards, there's a kind of a tipping point in year 5 or 6, upon which the number of cases will decline afterwards. And also, in the long run, both lines will converge. So basically, both implementation strategies are very beneficial. However, the impact differs a lot in the short run. So finally, I wanted to highlight a low endemic setting, which is the Maldives case study. In this case study, we wanted to showcase the impact in a country that is very close to interruption of transmission, or they very likely already have reached interruption of transmission, because for the last 5 years, no child cases have been detected there. And we compared 3 strategies here. One is a routine strategy. Basically business as usual. Secondly, we only include contact tracing, and third, we include contact tracing with a single dose of rifampicin. And since the number of new cases is quite low, it's between 5 to 10 in previous years annually. On the left panel, we hardly see any difference between the lines. However, if we take on the cumulative preventive number of new cases for all ages over time, we do see that having at least contact tracing in place would prevent at least almost 1 case on average in the long run. But when we also include SDR, we could prevent between 2 to 3 cases, and this is quite substantial if you consider that the annual number of cases is less than 10 cases per year. So to summarize this presentation, first of all, PEP and early diagnosis are both very promising tools to accelerate reduction of cases. We also have shown that there are geographical differences in impact which needs to be considered. And this is mainly caused by by the current case finding efforts, historic and also current case finding efforts in the country in place or area in place, but also the number of contacts per index patients screened. With a higher number of contacts per index patient will result of obviously in a larger impact as compared to a lower number of contacts. Finally, when we showcase that if we target high areas, we do see a larger reduction in the number of cases in the short run. And if we do that together with targeting contacts, it increases, of course, the impact on the leprosy incidence in the long run as well. So it is beneficial, especially in island settings, with a high endemicity to target a whole island in this case. And finally, we also illustrate a setting that is very close to interruption of transmission. And we also show that even in those areas, having SDR in place might still benefit the population. It basically prevents some of the cases. It doesn't add to the course of the decline because both are going to zero in the same pace, but still you can prevent some of the cases, and which is always good. So I would like to thank you for listening to my presentations. If you have any questions about this presentation, I think you can ask them during this session, but you can also send me an email on the email address that is now on the screen. Thank you very much.
Yeah, thank you to David for sending in this video. According to the program, we would have a separate discussion in two groups and then reconvene and have a more discussion in one group, and I think we just stick together. That would be the easiest, but it might help actually if we would make a circle of chairs so that we can easily see each other, and then also we won't need the microphone anymore. Is it easy to switch off the projector as well? Is that? And if there's anyone watching the live stream still, then you can just say thank you very much for watching, and we will be only having a discussion for the people who are present in person here. So thank you very much for watching, and I hope it was a learning experience.